Imagine a butterfly-shaped piece of tissue in your neck that's so powerful that if it malfunctions, it can literally cause your eyes to bulge from your skull.
Right, or trigger a physiological storm that actually kills half the people it strikes.
Yeah, it dictates how your heart beats, how your skin feels, and, well, how every single cell in your body consumes energy.
It is basically the ultimate metabolic control room, and when it's working perfectly, you don't even know it's there.
You completely ignore it.
Exactly. But when those controls short circuit, you see this massive systemic domino effect that touches every major organ.
Welcome to the deep dive. If you've ever felt your heart race after a sudden scare, imagine your body locking that feeling in permanently.
Just stuck in overdrive.
Yeah, and that is just one of the realities we are unpacking today. We've got our hands on a stack of highly detailed clinical medical notes, essentially a specialist's high-level cheat sheets, entirely focused on the thyroid gland.
And there's a lot of ground to cover in these.
There really is. So our mission today is to decode this data and take you on a journey through that metabolic engine room. We're looking at what happens when this gland goes into overdrive, how doctors hunt down hidden cancers, and the intense, almost extreme lengths they go to in order to treat them.
It really is a masterclass in extreme medical detective work. I mean, you can't just treat the symptoms here. You have to understand the underlying cellular mechanisms driving them.
Absolutely. So let's start with what happens when the engine runs, entirely too hot. The clinical breakdown details two major overactive conditions. You've got Graves' disease and toxic multinodular goiter, or MNG.
Right.
And these both result in the thyroid producing far too much hormone, but they're triggered in completely different ways here.
You have very different mechanisms. So take Graves' disease. It's actually an autoimmune condition. The data points out it's driven by TSHR antibodies.
Okay, break that down for us. What does that actually mean?
Sure. So to understand this, think of your thyroid cells having these little docking stations receptors that basically just wait for a signal from the brain telling them to produce hormone.
Like a key fitting into a lock.
Exactly. But in Graves' disease, your own immune system creates these rogue antibodies that perfectly fit into those docking stations.
Oh, wow.
Yeah, so they essentially hotwire the gland, they jam the on switch, so the thyroid just constantly pumps out hormone without the brain ever asking for it.
And the physical manifestations of that are just wild. I mean, it's not just feeling jittery or anxious. I was looking at the clinical symptoms, and it lists ophthalmopathy, which apparently affects about 50% of these patients.
Right, the eye involvement.
Yeah, that's the classic visible bulging of the eyes, isn't it?
It is, and the mechanism there is fascinating, though obviously very uncomfortable for the patient. Those same rogue antibodies don't just attack the thyroid, they actually target the tissues and muscles right behind the eye too.
Wait, really? The antibodies attack the eye tissue?
Yeah, it causes severe inflammation and a buildup of carbohydrate behind the eye, which literally physically pushes the eyeball forward out of the orbit.
That sounds terrifying. And it doesn't even stop there. The notes mention dermopathy, which creates these thick, red, almost orange peel-like skin patches.
Usually on the shins, yeah.
Right. And then necropathy, which is the actual swelling and clubbing of the fingers. It's crazy that a tiny gland in your neck is fundamentally reshaping your fingertips and your face.
It really highlights how deeply systemic thyroid hormones are. They touch everything.
Huh.
Now, contrast that autoimmune mechanism with the other one, toxic MNG.
The multinodular goiter.
Right. In toxic MNG, it's not an external antibody attacking the whole gland. Instead, you have individual nodules like little lumps within the thyroid itself that just go rogue.
So they just start working on their own.
Exactly. They start producing hormone completely independently of the brain signals. And this specific condition hits the cardiovascular system incredibly hard.
Yeah, the data shows toxic MNG presents predominantly with severe cardiovascular symptoms. But whether it's Graves or MNG, it looks like the initial medical response is basically the same. They use thionamides.
The antithyroid medications.
Right, but right below that in the notes, there's this bolded warning section for the side effects of these drugs. And it's pretty heavy. You've got fever, pruritic rash, which is severe itching, and arthralgia, or joint pain.
And those are just the mild ones.
Exactly. It escalates to liver failure and something called a granulocytosis, which just sounds bad.
It is bad. A granulocytosis is like the absolute red alert for an endocrinologist.
Why is it so dangerous?
Well, these drugs work by stopping the thyroid from using iodine to make hormones. But in rare cases, the medication actually suppresses the bone marrow.
Oh, no.
Yeah, it causes a severe, really rapid drop in a specific type of white blood cell called granulocytes. So your immune system essentially gets wiped out.
Just completely offline.
Pretty much. A patient might just come in complaining of a mild sore throat, and it turns out they have zero immune defense against what could be a lethal infection.
So doctors have to watch them like hawks when they're on these meds.
Absolutely. Frequent blood tests are a must.
Which brings me to a question about the long-term fix. The clinical summary refers to a definite treatment for these conditions, particularly for Graves, and that is radioiodine, RAI.
The definitive option, yeah.
So if the antithyroid medication is essentially putting a temporary governor on the metabolic engine to slow it down, is the radioiodine basically permanently disabling the cylinders?
That is a highly accurate way to look at it, actually. The medication manages the daily output, but it doesn't cure the underlying hyperactive tissue.
It's just a band-aid.
Exactly. But radioiodine is a targeted strike. The patient swallows a radioactive pill, the overactive thyroid cells absorb it, and the radiation destroys those specific cells from the inside out.
But the data explicitly states that a direct side effect of this definite treatment is permanent hypothyroidism.
Right. You are intentionally trading an uncontrollable overactive thyroid for a completely underactive one.
That sounds a little extreme, doesn't it?
It does sound extreme, but you have to weigh the risks. Managing an underactive thyroid with a single daily synthetic hormone pill is infinitely safer and much more predictable than letting Graves' disease ravage the heart and the eyes.
Okay, that makes sense. It's a calculated biological trade-off. We just shut the runaway engine down for good.
Exactly.
But that covers how the gland functions, the hormone levels. What happens when the problem is structural, like lumps, bumps, and nodules?
That's a whole different ballgame.
Right, so when doctors shift from looking at hormone levels to hunting for actual malignancy, how do they evaluate what they're looking at?
Well, they rely heavily on imaging.
Right.
Specifically the ultrasound.
Mhm.
But there's a huge caveat to how they have to use it.
Yeah, the diagnostic stats are super fascinating here. It says ultrasounds have a really high sensitivity, like between 83 and 99%, but a very low specificity.
Right, and that distinction is crucial. High sensitivity means the ultrasound is almost certainly going to spot the abnormality. If there's a lump there, it won't miss it, it catches everything.
But low specificity means it doesn't know what it caught.
Exactly. It's terrible at telling you exactly what that lump actually is. It casts this massive net, so it pulls in harmless, fluid-filled cysts right alongside really aggressive cancers.
So doctors need a highly specific checklist to separate the harmless bystanders from the actual threats.
They do, and the criteria for malignant features on US are incredibly detailed.
They really are. They look for nodules that are solid rather than fluid-filled. They look for them to be hypoechoic, meaning they absorb the sound waves and appear darker on the screen.
Right.
But then there are features like microcalcifications and central blood flow. Why are those specific things such massive red flags?
Because they basically tell a story of uncontrolled growth. So microcalcifications are essentially tiny specks of calcium.
Like little rocks.
Yeah, in a thyroid nodule, these are often the calcified remains of dead cells. See, when cancer grows really rapidly, it outpaces its own blood supply. It grows too fast to feed itself.
Oh, so parts of it die off?
Exactly. It leaves behind this trail of microscopic cellular debris that then calcifies.
Wow. And what about the central blood flow?
Well, benign nodules might have some blood vessels around the outside, kind of bordering it, but malignant tumors aggressively build new blood vessels straight into their center to feed their rapid expansion.
They build their own supply lines.
Right, it's a process called angiogenesis.
That makes perfect sense. But there's one malignant feature listed here that just sounds so weirdly architectural to me. It says taller than wide.
Oh yeah, that's a classic sign.
But why is a simple shape difference on a black and white screen such a massive warning sign before a doctor ever even uses a needle?
Because it's visual evidence of cells breaking the rules of biology.
How so?
Well, normal benign tissue naturally grows horizontally. It grows along the existing tissue planes of the body, taking the path of least resistance.
It just fits into the space it has.
Exactly. But malignant cells do not respect boundaries. They grow aggressively, pushing outward and upward, completely invading normal tissue planes.
So they just push through whatever is in their way.
Right, so when you see a nodule on a screen that is taller than it is wide, you are looking at an aggressive structure that is actively fighting the body's natural anatomy.
That is so wild. The physical structure literally reveals the hostile intent of the cells.
It really does. And to standardize all these visual clues, the medical community uses a grading system called TIRD.
Right, scoring the ultrasound from TR1, which is benign, up to TR5, which is highly suspicious.
And if it hits that suspicious threshold, they don't just guess, they go in with a needle for a biopsy, a fine needle aspiration cytology, or FNAC.
And that introduces a second diagnostic funnel, right? The Bethesda system.
Yes, Bethesda scores the actual cellular sample from category I to category 6, and that score directly dictates how much of the thyroid a surgeon is going to remove.
Okay, so for example, if a patient gets a Bethesda III, the notes call that a tibia of undetermined significance, meaning the cells look weird but not definitively cancerous.
Right, it's a gray area.
So in that case, the surgeon might perform a hemothyroidectomy. They just take out half the thyroid and leave the other half to keep producing hormones.
Exactly. But if that Bethesda score comes back as a category 6, that means it is malignant. That is a 97 to 99% certainty of cancer.
And at that point,
the standard protocol is a total thyroidectomy. The entire gland has to come out.
But here's where the pathology gets really complex. The clinical breakdown makes it clear that thyroid cancer isn't just a single disease.
Not at all, it's an entire alphabet soup.
Right, there are several distinct types of carcinomas, and they behave in radically different ways. Let's start with PTC, or papillary thyroid carcinoma.
So PTC is the most common type, accounting for the vast majority of cases, and it's actually particularly prevalent in children. What's crucial here are the genetic mechanisms driving it. The pathology reports often look for very specific genetic mutations called BRAF and RAS.
I've seen those terms before. How do those mutations actually cause the cancer?
Think of genes like BRAF and RAS as communication pathways. They tell a cell when it should divide and when it should stop dividing.
Like a biological traffic light.
Exactly. When they mutate, the pathway basically gets jammed in the on position. The cell constantly receives a signal to multiply, regardless of what the body actually needs.
So it just keeps growing. And for PTC, surgeons usually do a total thyroidectomy.
Usually, yes. Though there is a small exception for PTMC papillary thyroid microcarcinomas. If the tumor is tiny and lacks aggressive features, they might just take half the gland.
Got it. Then you have FTC, follicular thyroid carcinoma.
Right.
This one presents as a solitary mass, and the notes say it's the one that prominently features that internal blood flow we talked about earlier.
Yeah, the central vascularity. And because of how it spreads, the protocol for FTC is always a total thyroidectomy.
Okay, but then we get to MTC, medullary thyroid carcinoma, and this one seems to be a completely different biological entity.
Oh, completely different. MTC doesn't even originate from the standard thyroid cells that make iodine-based hormones.
Wait, really? Where does it come from then?
It originates from C cells, which are just this minor cell population hanging out in the thyroid.
Huh. The pathology data highlights that while 90% of these MTC cases are sporadic, meaning they just happen randomly, 10 to 25% are familial.
Right, inherited.
They're strongly associated with these genetic syndromes called MNIIA or MEN-IIB, driven by a mutation in the RET proto-unc gene.
And because MTC comes from a completely different cell type, doctors can't monitor standard thyroid hormones to track the cancer. It just wouldn't work.
So what do they use?
They have to use highly specific tumor markers, calcitonin and CEA.
Let's define CEA for a second. That's carcinoma embryonic antigen, right?
Yes, exactly.
It's a protein usually found in developing fetuses, but certain aggressive tumors essentially reactivate it, so it makes for a great tracking beacon in the blood.
That's right, along with calcitonin, which these C cells naturally produce anyway. But in MTC, the tumor goes crazy and produces massive systemic amounts of it.
And this leads to one of the most surprising systemic effects in the entire document. When MTC spreads, when it causes distant metastasis, the symptoms listed are bone pain, severe diarrhea, and facial flushing.
Yeah, it's quite a presentation.
I mean, a patient might go to their primary care doctor complaining of debilitating diarrhea and a red, flushed face, and the root cause is actually an aggressive tumor in their neck.
I know, it seems totally disconnected until you look at the mechanism.
How does that even work?
Well, these tumors are essentially hormone factories. When the cancer multiplies and spreads, it dumps enormous quantities of calcitonin and other active biological substances directly into the bloodstream. These substances circulate systemically and cause the blood vessels in the skin to dilate, which causes the severe flushing, and they severely hyperstimulate the gastrointestinal tract, which causes the diarrhea.
Wow, so the calcitonin isn't just a diagnostic beacon, it's actively causing chaos in the body.
Exactly, it's a very active hormone.
The data specifically notes that doctors measure the calcitonin doubling time. If the level of that marker doubles in less than 1 year, it indicates the cancer is multiplying incredibly fast, signaling a much worse prognosis.
Which is why surgical intervention has to be so definitive. But surgery alone often isn't enough.
Right, because the surgeons remove the thyroid, they might even do a central neck dissection to pull out all the nearby lymph nodes.
Yep.
But how do you hunt down the microscopic cancer cells that might have already escaped into the bloodstream or are just hiding deep in the tissue?
You have to exploit the biology of the thyroid cell itself. And that brings us back to the radioiodine therapy protocol, but used here as a post-surgical cleanup operation.
We talked about RAI earlier to treat Graves' disease, but in the context of cancer, the goals are completely different.
Very different.
The clinical notes show it improves overall survival, significantly reduces the chance of recurrence, and allows doctors to accurately monitor the patient for the rest of their life using a protein called thyroglobulin.
Right.
But the preparation for this nuclear option is just physically and psychologically intense.
You have to remember, normal thyroid cells and thyroid cancer cells naturally absorb iodine from the blood. It's their primary food source.
It's the only thing they eat.
Exactly. So to force any remaining microscopic cancer cells to absorb the radioactive iodine and destroy themselves, doctors have to make those cells desperately hungry.
The protocol outlines 2 ways to induce that starvation, and the traditional method is brutal. Patients have to completely stop taking their levothyroxine, their synthetic daily thyroid hormone, for 28 full days before the treatment.
It is a tough process. The mechanism here relies on the brain's feedback loop. When you take away the synthetic hormone, the brain senses the body is running out. So the pituitary gland starts screaming for more, pumping out massive amounts of TSH thyroid stimulating hormone. The goal is to drive that TSH level sky high, above 25 to 30.
But the reality for the patient is an induced state of severe, profound hypothyroidism. For a month, they are lethargic, freezing cold, depressed, and just physically exhausted.
It's a very difficult month. But the alternative modern method avoids that month of suffering. doctors can now inject recombinant TSH, known as rhTSH, over just a few days.
Oh, so they just fake the signal.
Essentially, yes. It artificially spikes the TSH levels, creating that same biological hunger in the cells without making the patient endure the actual hormone withdrawal.
That's incredible. So you purposefully starve the remaining cancer cells or artificially stimulate them so that when you finally introduce the radioactive iodine, they greedily gobble up the absolute only iodine available, which happens to be a targeted radioactive poison.
Exactly. It guarantees that every remaining rogue cell acts like a sponge, absorbing a lethal dose of radiation from the inside.
But the fallout from this treatment is severe. The lifestyle restrictions listed here are really heavy because the patient is literally emitting radiation. They require strict isolation for 14 to 25 days.
It's a real quarantine.
Yeah, they can't sleep in the same bed as their partner, they can't hug their children, they have to use separate bathrooms.
And the toxicity extends to reproduction too. Women must avoid pregnancy for 6 to 12 months because of the radiation risk to a developing fetus, and they must stop breastfeeding weeks before the therapy.
It even impacts men, right?
Yeah, men are advised to avoid fathering a child for 4 months. The systemic shock is so profound, it can even cause amenorrhea, the temporary loss of a woman's menstrual cycle, for 4 to 10 months.
And after enduring all of that, how do doctors actually confirm the cancer is gone?
They look for a footprint, specifically thyroglobulin or T-drag.
What exactly is that?
Thyroglobulin is a protein that is exclusively produced by thyroid tissue. Nowhere else in the body.
Okay, so the follow-up protocol requires checking stimulated TG 9 to 12 months after the surgery and radiation. Because the patient shouldn't have a single microscopic speck of thyroid tissue left in their entire body, their TG level should effectively be 0.
Right, and the threshold is incredibly tight. A level under 0.5 micrograms per liter means a disease-free status.
But if it's higher,
If that number creeps over 2 micrograms per liter, it means persistent disease. There are still thyroid cancer cells surviving somewhere in the body, producing that protein.
it is a highly methodical, controlled destruction of tissue. We find it, we surgically remove it, we hunt the remnants with radiation.
It's very step by step.
But reading the final section of this clinical breakdown, you realize the thyroid doesn't always wait for a doctor to initiate a sequence. What happens when the thyroid unleashes destruction entirely on its own terms?
That is thyroid storm.
Yeah.
It is the most acute, dangerous medical emergency in the entire realm of endocrinology.
The data pulls no punches here. Right next to the heading thyroid storm, there's a simple, terrifying parentheses. 50% mortality. Half the people who go into the state do not survive.
Because it is a total uncontrolled metabolic meltdown, all the regulatory systems just completely snap.
The precipitating factors, the triggers that set this off, are usually major physical stressors on a body that already has an underlying, poorly managed, overactive thyroid.
Right, it's like a spark in a powder cake.
Exactly. Things like severe systemic infection, major surgery, the trauma of childbirth, or even something as seemingly routine as IV contrast dye used in a CT scan.
Any sudden stressor can push an already hyperactive system right over the edge into this terrifying cascade.
And the symptoms reflect a body basically burning itself alive. Severe fever, extreme tachycardia, which is a racing runaway heart rate that can't be controlled, altered mental status and delirium, severe gastrointestinal and hepatic dysfunction, ultimately leading to congestive heart failure.
It's catastrophic. To diagnose it rapidly, doctors use the Birch-Wartowski scale.
Okay, how does that score work?
Well, a score greater than 45 means a storm is actively happening right now. A score between 25 and 45 means a storm is imminent.
But when a patient hits that threshold, the treatment protocol isn't just a list of medications. It is a highly specific, non-negotiable, sequential order.
Yes, the order is everything here.
That sequence really caught my eye. It reads like the exact manual for safely shutting down a compromised nuclear facility.
That's a great analogy.
You start with basic physical stabilization, cooling the patient and correcting their electrolytes. You have to put out the immediate physiological fire. But then step 2 is propranolol, a beta blocker. Why that specifically?
Because you have to protect the heart before it beats itself to death.
Right.
Propranolol blocks the thyroid hormones from overstimulating the cardiovascular system, bringing that massive heart rate under control and lowering vascularity.
Okay, so the heart is shielded. Step 3 is PTU, or propylthiouracil. That's the anti-thyroid drug we discussed earlier. It shuts down the production line inside the gland. But step 4 is where I got confused. Step 4 is giving potassium iodide. But there's a massive glaring warning attached to this step. Lugol's iodine must be specifically avoided because it may induce thyrotoxicosis.
Yes, that is a critical distinction.
Why is one form of iodine the cure, but the other form acts like throwing gasoline on the fire?
It comes down to a biological phenomenon known as the Jod-Basedow effect, balanced against the Wolff-Chaikoff effect.
Sounds complex.
It is, but think of the thyroid as a factory, and iodine is the raw material it uses to build hormones. Potassium iodide, given in a very specific rapid dose after the factory floor has been shut down by the PTU, triggers a failsafe in the thyroid.
With a fail-safe.
It temporarily paralyzes the gland, stopping the release of the hormones already stored up inside it.
But Lugol's iodine is different.
Very. Lugol's is a highly concentrated solution. If you give that wrong type of iodine, or if you give any iodine before the PTU has completely shut down the factory's production line, you're essentially backing up a dump truck of raw materials into a factory that is stuck in overdrive.
Oh, what?
The thyroid will gorge on that sudden massive supply of iodine and instantly convert it into a lethal surge of new hormone. The patient's heart will fail.
That is terrifying. One wrong step, one mixed up medication, and the patient dies.
It's true. And finally, step 5 is prednisolone, a heavy steroid.
What does the steroid do at the end of all this?
It does 2 things. It reduces the systemic inflammation, but crucially, it stops the body from converting the hormones currently circulating in the blood into their most active, dangerous forms.
Wow. You cool the body, shield the heart, shut down the factory, lock the warehouse doors, and neutralize the product already on the streets.
It is precision medicine under maximum pressure.
So what does this all mean for you? We've traveled from the overactive engines of Graves' disease, where the body's own immune system hotwires the cellular docking stations, to the architectural hunt of ultrasound screens searching for microcalcifications in cells that aggressively grow taller than wide.
It is a wild journey.
It really is. We've mapped out the surgical strikes on carcinomas, the intense artificially starved radioactive isolation required to hunt down microscopic survivors, and finally, we've walked through the precise, terrifying biological sequence required to survive a true thyroid storm.
It is a profound reminder of how deeply connected a single, butterfly-shaped structure is to our overall survival and, well, the incredible biological detective work required to keep it in balance.
But before we go, there is one final, completely counterintuitive